All right, Derek, on you.
Because that'll be a whole can of.
Welcome to the Well-ish podcast, sponsored by Iowa Specialty Hospital, where real life meets better health. We're your hosts. I'm Derek.
I'm Anthony. Let's dive in.
Oh my gosh. All right, everybody. Well, welcome into the Well-ish podcast. Super excited to be here today. We're your hosts. I'm Derek.
I'm Anthony.
He's got it in that time. And we are here with Caitlin today. Super excited that she's on with us. We've been waiting for months to get this interview. And we just started. We haven't even been going for months yet. So we're super pumped that she's early on. So it's super exciting. But yeah, let's just start off by, Caitlin, you telling us a little bit about who you are, what you do within, obviously, our title sponsor, Iowa Specialty Hospital. And let's just jump in. So tell us about you a little bit.
Okay. Wow. I mean, do you want like from the beginning of my childhood or,
Yeah.
like,
No, actually. Where'd you grow up?
I was born and raised in a small lumberjack. I don't know. It's that's what they do up there. They harvest timber. Community in northern Wisconsin. Is this like a good?
Wait, is that
place
where
to do
Paul
this?
Bunyan? Or is
Yes.
that Minnesota?
That's Paul Bunyan.
Paul Bunyan?
And his ox
Okay.
Blue.
So
Yeah.
lumberjack.
Yeah.
Okay.
My hometown, Phillips, Wisconsin. You can Google it. We are the Phillips Loggers.
Shout out.
Not joking. That is our mascot.
I
We
love
are
it.
the Phillips
That's great.
Loggers. I lived there till I was 17, thrived. Then I went to college and
The thriving
pursued.
stopped.
Yeah. The thriving was in short supply. But in all reality, no, I am a registered dietitian by trade. So I've been a dietitian, for 13 years, going
Cool.
on 14 years. So
Yeah.
which, I mean, it's cool to say out loud, right? It gives me some like street cred, but I really don't feel like it's been that long. I started my career off at the University of Iowa, and then I worked for Hy-Vee for probably about 4, almost 5 years, which we all have in common, at different times in our lives. And then I was an inpatient dietitian at Mercy One in Mason City for 5 years, and then I came to Iowa Specialty. I came to Iowa Specialty on the diabetes education front. So, and that's actually, if I would say I had to pick a favorite job as a dietitian, that was definitely my favorite job.
Really?
Was diabetes ed. I
Cool.
liked that more than anything else I ever did in the world of dietetics. I don't know if it was a combination of the people that I worked with and the patients, or maybe just the environment in which you're educating. I feel like diabetes patients are receptive for the most part.
Yeah.
And you get this progression with them. You see the numbers actually improve. And so, weight loss is probably similar. But I would say, yes, I love diabetes ed. Then we just kind of grew as a company. We started exploring different avenues and expanding some of our services, which we'll kind of talk about here today. And that brought me away from the world of diabetes and into the world of GI. And now that is kind of transformed into leading our current GI team, our GI team growth, and our functional GI program, which we will get all into today. So I don't touch the dietitian world as much, but I will say I wouldn't have wanted any other background coming into it. I think it gives me a very unique perspective compared to maybe like a nursing background or a business background. We are experts at motivational interviewing, right? We are experts at coaching. And I feel like that's served me better than anything else. So
Interesting.
yeah. And here I am.
And here you
with
are.
you.
So what's your current title now?
I am the Gastroenterology Leader at Iowa Specialty Hospitals and Clinics. Where's the camera?
There.
We're snipping that for sure.
I love that. Instagram ready.
Yeah.
Come on. I love that.
I think that's such a cool story though. Like
Yeah.
as a dietitian, like a lot of times I think, especially going through the internship, you feel like there's maybe only so many routes you can go. But then once you get into the real world, and even during the internship, maybe you start to realize this, but there's so many different routes you can go with it as a dietitian, whether you still practice dietetics or, start leading different areas or different groups, right? And you're a great representation of that. Yeah. And the people skills that we get, I think you touched on that pretty well. Like, we really practice that in undergrad and even in graduate school now. And I think that goes so far inside the profession, but also, like, outside too,
Mhm.
like, being able to, like, navigate conversations
Yep.
is super important. I've come to find out as, we get older. So,
Right.
yeah.
Tell me a little bit just still about you just for a little bit here, but, like, tell me about the kind of the difference that you found between your experience in clinical dietitian versus the kind of the diabetes education side of things.
So, I mean, and this is, I don't wanna say controversial, but my thought, even through my undergraduate education and through my internship and everything, was when you are in an acute care situation, so when you're in a hospital and you're providing clinical nutrition, it's really a survival skills education at that point. Your patients, when they are in a hospital, are not really in the capacity to best learn and make life changes that are going to last. Your role is very important there, but I think it's very different than outpatient education. The relationship you develop is different. It's a much more kind of one and done situation. You are coming in someone's maybe worst time, giving them just enough information to get them on their way, and then you hope it goes well. And you hope they follow up with somebody that can, help them further down the road or dive more into their education. I also feel like outpatient is more individualized because you get to build the relationship with the person and then you get to see them back and see what they struggled with or what they strived with, and you can make your recommendations based on that. So, not that clinical is cookie cutter, but I would say you have to be on your game more in terms of the science behind what we do, and a lot of people don't understand how much science and physiology that we understand with our background, right? Like, if we put up, a picture of the Krebs cycle back here, we're all gonna have some sort of seizure, right? We had to do that at some point in time. So, the clinical part of it is very technical, especially when you get into nutrition support and things like that. So, which was great. I did enjoy that, but I'm a people person and I'm a relationship person, and I really enjoyed the vibe of education in the outpatient setting a lot more. So,
Yeah. I don't think that's controversial. I think it's just a
no,
matter of, like, yeah,
yeah,
it's almost like reactive being inpatient
very,
versus,
very
I mean, I wouldn't say necessarily proactive if you're seeing it outside, like, after being inpatient, but, that relationship part really comes into play, like you're mentioning.
right.
Yeah.
No, it is reactive because there's no reason you're gonna be in that person's room unless they're having a problem that requires your assistance, right? Um, I had a professor that, or not a professor, a preceptor in my internship that always said, "There's no such thing as a nutrition emergency." That's what she would say. She was like, "So just calm down and do your best, but there's no such thing as a nutrition emergency." And that, like, it's a good thing to keep in mind, and I think is what she was really getting at is, like, we gotta play the long game here, right?
Mhm.
This is if we are going to be successful, we are not emergency management people. We
Yeah,
are we are long-term success people.
yeah. How do you feel like that kind of thinking has translated now to GI and what you do now?
One thing that I really didn't realize was how many patients in the gastroenterology world are chronic patients. We have so many people that deal with a chronic GI illness or have many acute bouts of something that happens over and over and over. Very rarely do we see a patient fix them and send them on their way right away. It's usually more complex and more in depth. And so you do have a chance to develop the relationships. My providers in the GI department, they know their people. And they know them and they come back and they know their story and they know what's worked for them, what hasn't. And so I didn't realize how chronic the patient population was gonna be, which is kind of interesting.
Yeah, and with that complexity that you mentioned, like, how do you guys go about that? Is it the practitioners doing it all, or like, what have you noticed?
In traditional GI, you are, managed either by your gastroenterologist or a mid-level provider, your NP or your PA. Um, but their training is pretty extensive when it comes to GI in terms of what other systems play into that function. So they're not only looking from esophagus down to rectum. I mean, they're looking at how your other digestive portions of, like, of your system play in. They are looking at the liver, they're looking at the gallbladder, they're looking at those external stressors. They're paying attention to what their diet is, and they're not giving that education, but, I would say my providers are very good at looking at a whole body. Even though you're coming to see GI, you know,
Mhm.
they're looking outside of just the GI tract because of how much communication there is in our body between our gut and our digestive system and everything else. So,
Wow.
they're
Yeah.
like they're pinpointed, but they're broad. Does that make sense? Right?
Mhm.
Like,
Mhm.
they're treating a specific set of organs, but they look outside of them
Yeah.
to find the problem,
So it's
which is I think really hard. Like, I couldn't do what they do all day.
Yeah,
It's a lot to look at. They're
it's
like,
a
"Well, it could
puzzle.
be this, or it could be this, right? This could
Yeah.
be unrelated." So
Yeah, and how do you decipher that? I think,
right.
I'm gonna totally pick on something that I just loved when I learned when I was in school, and that's how we're hollow. I think
Yeah.
that's a good point, like, from the mouth to the anus, like, that's just a tube going straight
Tube.
through your body,
Yep.
So if you're just a GI practitioner, you're in a GI field, like, you can't just focus on that because obviously so many other things are, influencing or being affected by what goes in also is,
Goes in, what
like,
comes
working
out,
out. Yeah,
right? Like,
yeah,
yeah.
yeah, it's crazy. I never thought about that either, about how specialized you do have to be in the GI world, right?
Right.
Especially once you start getting into like the functional GI world, which we'll
Mhm.
get to here in a little bit.
Yeah.
Um, so one thing I don't know if we really touched on is how did you get into becoming like a part of that GI? Um,
I was approached by some of our leadership at Iowa Specialty that we had a provider, Dr. Adams, who is our gastroenterologist, who was very passionate about expanding more on the functional GI population, which, we can define in a second. Um, And so they were looking for somebody that would be able to create that program, understand the processes, the side no one wants to think about, like the epic portion, the billing portion, right? Your EMR, all of your nitty-gritty stuff, but maybe somebody that also kind of understood the patient. And I was lucky enough that my leader was able to say, "Hey, I think with Caitlin's dietetics background and with her counseling background, but also having some experience in leadership and clinical, like, I think she might be able to see this whole functional GI patient and make us a really good program." So I was approached with it and I thought, like, why not? So, that's kinda how it happened. It was an idea that one of our docs had, and they needed somebody on the ground to build it and run with it, and I was lucky enough to have been approached to be that person. So,
so you just dove right in.
yeah, yeah, and some things I knew a lot about and some things I knew nothing about, so
Yeah,
I learned.
that's awesome. I think that's the cool part about that though, is like you were somewhat interested, but you also trusted in your background,
Right,
right? That would get you there and, look where you are now.
right.
Yeah,
Still
so
a lot of things I don't know, but I like to learn. We
yeah.
like to learn. I think,
Oh, yeah.
you know, as a profession, as a world of dietitians, like, we like knowledge.
Yeah.
Yeah.
I mean, really, that's why we're sitting here today
Right,
is not only because we wanna try and share things about, the patients and the experience and all of that with people, but also because I mean, I'm excited to learn more about about the functional GI and kind of what that means and what that can mean for a patient. So, I think let's go ahead and kind of jump in. So, can we just start talking about kind of what that is, what the program is like, and the people that might end up there?
So one thing that's actually really interesting, and I just learned about this summer, is the term functional GI is kind of phasing out in the world of GI. And what they're really calling this is disorders of gut brain interaction.
'Cause that's
or
easier to say.
DGBI, right? Because that's easier, and
Yeah.
even DGBI doesn't
Flow very well.
flow.
Yeah. Yeah.
No. So, but I think that the reason the American College of Gastroenterology and some of those kind of governing bodies in GI have started to address these conditions as DGBI is because really at the base, at the core, it is a disorder of the gut brain communication. We call it functional GI, and the reason we call it functional GI is because at its simplest, it really is an issue with the function. So something between top to bottom is not functioning the way it is supposed to be, but we cannot give it an organic source. So it's not Crohn's. We can see Crohn's in a scope, right? It's not ulcerative colitis. We can see that. It's not celiac disease. I can test for that. It's not colon cancer, it's not hemorrhoids, it's not something that we can diagnostically confirm. So, a lot of times, it just gets lumped into IBS or irritable bowel syndrome, which is accurate, that is a functional GI problem. Sometimes it's an undiagnosed thing that people just say, "Oh, it's like tummy troubles." Like, "My bowel movements are never right. They're either loose or they're not." I have chronic constipation, but I don't know why. Um, so a lot of times it's that something's not functioning right, but I don't know what it is. And it might not have a diagnosis, right? We might not be able to put a label on what's going on other than dyspepsia or chronic cough
Mhm.
or, something of the like where we can name what's happening, but we don't have a reason. And so those things fall into your functional category. So they're all really hard, I think. Like the the people that come into this program likely have been in the healthcare system for a long time trying to figure out what's going on with them because they by definition they are things that have been happening for 6 months or longer, and honestly usually it's years. People that have been coming to us, I've been struggling with this for years, but the criteria to formally diagnose is more than 6 months. Yeah. And then there's some different criteria in terms of altered bowel movements or different symptoms that you have to have chronically or meaning like every single day or 5 out of the 7 days a week or, whatever it is.
Yeah.
So there's actual as in all medicine, there's an actual numerical criteria that we can put to these things. But really if you think about the human component, these are people that maybe were underdiagnosed, misdiagnosed, utilize healthcare quite a bit because they're always in with something. Maybe didn't ever get an answer, maybe got an answer for a while, felt better, now it's back. So, nobody's doing great,
Yeah.
when they come into the functional GI program. They're not here because things are rocking and rolling.
Yeah. They don't start there. I think that's something
They
important.
don't start here, right.
Yeah. Yeah.
They likely started with their primary care provider. I have vomiting after every time that I eat. And maybe they worked him up for some things. Maybe they tried some things, and who knows how long that had been going on. So you're very accurate. Usually, people have seen at least their primary care, maybe even another specialist. They've likely had different diagnostic procedures, and we still don't know, or we know and we can't manage what's happening symptom wise, and then they end up with us in functional GI.
I mean, right now, how are they ending up with you guys? Is it usually by referrals? Are people just looking you up? What does that look like?
So far, it's really referral only.
Okay.
We do not require a referral.
Mm.
So, someone can self-refer into the program, but everybody starts with a visit with our nurse practitioners, with one of them. We have 3 right now. So, if it is someone that's self-referred, that first visit is really gonna get to the bottom if they're in the right place. And honestly, some even if they're referred in by a different provider, that first visit is getting to the bottom of if they're in the right place. Um, and if they really need more of that traditional GI support, we have that. If they need a colonoscopy or if they need some sort of, biologic and they ends up having Crohn's disease, something like that, we can provide that, but the first step is that analysis by our nurse practitioners, and, they kind of drive the boat from there.
Yeah. Yeah, make sure they're in the right place before
Right.
just, like, going down the rat
Yeah. Make
hut.
sure we really do have a functional GI issue here.
Yeah.
Yeah.
Yeah, interesting. And one thing that's really cool looking about our program is, we mentioned how maybe traditional, GI has the, the nurse practitioners or the medical, provider, but also, you guys are adding in mental health therapists and dietitians as well.
Yeah.
Do you wanna talk a little about why you guys do that?
Yeah. So we have like a support staff. And sometimes they're referred as like ancillary services, but I just don't feel like that really does it justice, right? It's not ancillary.
Interdisciplinary team.
Yes, an interdisciplinary team, but we have dietitians, mental health therapists, physical therapists, speech therapists. Um, and that's kind of our team. And then we also, I guess technically we have psych. So the medication side of mental health as well. So we have the counseling part and the medication side because sometimes you need a combination of both to figure out a control for what's going on. Yeah.
Mhm.
So on our mental health side, we have providers that perform what's called cognitive behavioral therapy for gut brain interaction. So it's a 10-step program that they've been trained on. That doesn't mean that every person sees them 10 times. It's very individualized. But what they're trained on is kind of how to retrain that gut brain highway and addressing 10 reasons why it might not be doing what it's supposed to be doing.
Wow, that's cool.
Yeah, it's super neat. They therapists do cognitive behavioral therapy for lots of different reasons, but what's nice about the training they've done for functional GI patients is it really does direct what things we can control brain-wise that end up as physical symptoms from our gut.
Yeah, it's not just what you put in, right?
Right,
It's yeah.
right. It's really like a kind of a circle, right? What you put in controls what comes out, and what comes in controls what comes out. What it's like it all there's a graphic, like a gut brain connection graphic that we use on some of our promotional materials, and
Mhm.
it's got like brain up here and the gut down here, and it's got these arrows that are like, like it everything's connected.
Yeah.
Did we just find a good,
Oh,
cover
yeah. I
photo?
think
Yeah,
I
so.
yeah,
think
I
so.
was just thinking,
We're
like,
gonna
I
need
gotta
that.
remember this, I gotta
right.
remember this.
Well, I mean, if you think about it from, the dietetic standpoint. So say I have anxiety. Okay, well, that is causing me to have stomach pain. But having stomach pain causes me anxiety. And then worrying about what I'm gonna eat that might make it worse causes me anxiety, but that also changes what I'm gonna eat. And now my nutrition's altered because I'm restricting what I can eat because I don't wanna get stomach pain because it's gonna make me anxious. I mean, like, right?
It's just one
And
aspect of
that's
it, right?
just
You just
one
told
Yeah,
aspect.
yeah,
yeah.
Right.
but
And then you even think of, how then external things start playing in,
yeah.
your environmental factors and things like that. So even though you've got your brain and you've got your gut and you're trying to control force here, then you have the world that's also in. So that's one thing that I think is probably between that and diet. I mean, almost every person that has a disorder of gut brain interaction could benefit in some capacity from the mental health standpoint or the nutrition standpoint. Maybe some people need more targeted therapy here, there, but I think it's kind of what we've seen is everybody can use those too.
Mhm. Yeah.
I think that from hearing all of that and all of the different aspects of care that someone can receive from us or if you're listening to it really far from us, right? There's a lot of different ways to go about solving what problems might exist. And so I think, in my experience, I run into patients that have clearly put a pause on trying to solve their problem because they just can't deal with it anymore. And they're like, you know what? This just is what it is for a while. I'm just going to live with it. And so I think it's really important that anyone who has gotten to that point, it's like there's got to be another stone to turn over.
Right? We haven't done it.
And there's a lot of opportunity with us to look under those stones. So keep going because you
Yeah.
can find it.
Yeah.
And it's crazy how much people that struggle with functional GI problems for a long time become very immune to their problem.
Mm.
They learn to live with that pain or that discomfort or that interruption in the normal function, and even just the slightest bit of relief, they will tell you that, like, their world changed because they forgot what it was like to not go to the bathroom 18 times a day. And they're like, "I only went 5." And here I'm thinking like, "Man, I'd love for it to be 2," you know? But their life is different. So they get to the point where they just deal with it, deal with it, deal with it to the extreme that
And it's their normal at
it's
that
their
point.
normal. It's their normal, yeah. And
And
so
what a rewarding experience though from a caregiver side,
right.
right? Like, that's so cool to make that just that little change and to watch someone's world completely shift.
Yes.
That's awesome, right? How fun is that?
We had an adolescent, we do see, like, as young as 10 or 11 in the
Mhm.
program.
Okay.
Um, and so we had an adolescent that was struggling just different aspects of the GI spectrum, and it was impacting school. It was impacting wanting to go out and play. It was impacting sleep, you know, grades even, because you can't concentrate in school when you feel terrible, and
And get the bad
you
sleep.
don't eat anything at lunch when you're afraid how it's gonna make your belly feel, and then how how much do you wanna go and play at recess when you haven't eaten anything all day, and right, so this whole confounding factor. So, long story short, this patient is just like a new kid, like, getting great grades, made new friends, plays at recess, joined a sport, like,
Everything she thought
different.
she probably would never be able
Yeah,
to do,
and
right?
her parents were to the point where they're like, "Well, what else is going on?" They were really like, "I don't know if we're gonna be able to fix this for her, like, this is what her life is gonna be like."
Mhm.
Maybe this is the struggle she's gonna have into adulthood, and she can't make friends or she can't focus, and then it turns out really it had nothing to do with her.
Yeah.
It did, but
Yeah.
it was a problem that
The functional
it was a
problem.
functional problem, yeah.
And one that could be solved.
Right, right,
Was, which
yeah.
is that's so cool.
So now she's just like, happy girl, rocking and rolling. I know.
That is really cool, actually. I wanna pull that word you used, though, is solve. Like, how many of these cases you think are solved versus managed? How do you
That's
feel
a
about those
really good
words?
point. I have been kind of cautioned to use solve because they are such chronic issues, and a lot of times they're cyclic issues, so they can come back in different seasons of life depending on what we have kind of let out of our control. So manage is a much better way of looking at it, and that actually is, our mission is management of symptoms that gives you the quality of life you desire.
Oh,
So
that's pretty cool. I didn't know that was the mission.
right. So it everybody's is different, right? What you want is different. Your level of functioning is different. So somebody might say, I want to climb Mount Everest and I need to have my gut under control enough that I can go do that. And somebody's might be, I just don't want to go to the bathroom 18 times a day.
Mm.
So you got to figure out what the quality of life goal is. And then if you can manage symptoms to get them there, then I would say that's a solve. Right.
Yeah, absolutely. Yeah. That's, I think something that it was talked about a lot, especially around that, registered dietitians is, we're just trying to meet the patient where they're at.
Where they are.
Where do you wanna go? What do you wanna do?
Yeah.
A lot of times people either we're gonna have the golden answer, or they wanna get yeah, the magic bullet, or, they see someone else doing something, and that's where they wanna go. And then how do you kind of, get them to think about where they want to be? And then we go from there, right?
Mhm.
Because you can't base it on anyone else, right? You're the way, uh, you eat, the society, like, the environmental factors that you have, like you mentioned, are all gonna be different than those individuals, so individualization is incredibly important. It sounds like that's a pretty big value for your guys' program.
Yes. Yeah, and I think that that goes through all the different support systems that we have within the functional GI program. Like, when we send somebody to the registered dietitian, I think the old way of thinking about IBS and functional gut is we just eliminate everything, right?
Mm.
We do a low FODMAP diet. We get rid of it all. Anything that can trigger. And then we'll try to add it back in and see what happens. And sometimes that is the way we have to do it. And there are some conditions that truly do respond very well to eliminating some of those fermentable things. And, I'm not talking bad on the low fat nut diet, but we've learned there are a lot of other ways to go about managing disorders of gut brain interaction from a nutrition standpoint. And you've got to meet the person where they're at.
Mhm.
So if the relief they're seeking can be found with a few really small changes, then that's where we're going to live, right? We're not going to push them to do massive diet modification when we're able to achieve what they desire in something smaller. So the nutrition part of it also, I just think there's not a person in the world that couldn't benefit from a good nutrition sit down, right? Just a check of, do I eat fiber? Do I drink water? Do I eat fruits and vegetables? We all can benefit from
Reflection.
just a reflection, right, of our
Hey.
of our nutrition,
Mhm.
whether we're having problems or not. So
Yeah.
so that's why I think your mental health and your dietitians, that's almost for everybody. Now, our physical therapists are great. That's more of a disorder of pelvic floor. So that is a more specific subset of patients. Not everybody's having a pelvic floor issue, but a lot more people than I realized can benefit from pelvic floor therapy. Um, so that's something that we offer, and then we're also in the process of kind of expanding that offering by getting some strategic partners around the area, and we have lots of patients that need it in lots of areas of Iowa specialty, and so we're trying to work to get that access to that a little bit better currently.
Without getting to the specifics, because
Mhm.
you're not a PT, but,
I am
like,
not.
why do you think that's so large? Or why do you think so many people can benefit from the pelvic floor?
Well, because with working on the pelvic floor, you can work on rectal or incontinence issues from, like, the fecal side. You can work on, like, bladder, urinary type things, and then you also, like, it radiates up into that gut control too. So there's a lot of different organ systems that can be touched by a good, healthy pelvic floor. So it's not a lot of times people think women who had babies, and now we
Mhm.
got, like, leads on that pelvic floor, but, I mean, you gotta think of it's the rectum, it's the bladder, it's the abdominal wall, even, like, the low back and how it supports. So and that's that's the extent of my knowledge
Yeah,
there.
I think that's a good thing
I
to
I will not speak out of my
step
credentials,
out of that.
but it is, again, like, it's all connected, right? Everything's connected. So, I think when I first thought pelvic floor, I was thinking women.
Mhm.
Women who maybe need help after they have kids or they have incontinence issues. That's where pelvic floor went for me until I realized all of the things it actually kind of encompasses.
Sure.
And there are definitely some people that don't need any sort of pelvic floor therapy, and that's fine. That's great. But it's an offering we have. Same thing with speech. So not everybody needs a speech therapist, but we do have some people that, what's a good example? Say they've had GERD for a long time. They've controlled their GERD, right? It's better, but they have a feeling that something is stuck in their throat from that very long time of kind of that acid coming up, and they cough, and so now they either have this, like, chronic throat clearing or chronic cough or this feel of something being stuck, and we know that there's nothing organically wrong, there's nothing stuck in there. They're not having reflux anymore, but they essentially have to recalibrate that,
Mm.
and that is a gut or, gut. It is a communication between brain and organ.
That's so cool.
Oh
Yeah.
my gosh. This is
Yeah.
yeah, this is
Isn't it?
awesome.
Yeah. No, I'm glad you touched on those 2 because speech therapist and also physical therapy,
Yeah.
like, those 2 areas I feel like you wouldn't really necessarily think about, including mental health. I think now more than ever, like, people might put those 2 and 2 together.
Yeah, I think we're getting better at recognizing how mental health fits in, but yeah, I do get that question a lot. Why would you need PT or speech? Yeah.
Mhm. Yeah.
While it might not be everybody, like, the need is there.
Mhm.
Just think how awful that would be. Say you did have something that you fixed, right? We managed, but I still
Mm.
am uncomfortable.
Yeah.
because
Mhm.
of the long-term effects of whatever that was. So if somebody can help my brain stop doing stupid things to my esophagus, right? So don't feel like I have a swallowing disorder, heck yeah. Like, think about life-changing there. 'Cause,
I
those people probably had a scope put down there. They're like,
Yeah.
"There's nothing in there,
Yeah.
Cindy. You're fine."
It's all in your head.
Like,
But then, I mean, really, it
it
is.
really it
Yeah.
is, right, but
Yeah.
it just, like,
But let's
you
help you figure that out.
yeah, yeah, there's an actual, like, laryngeal recalibration
Yeah.
that can be done, it's very cool.
Think about how good that would feel as a patient
Oh my gosh.
to have this chronic issue that has been adequately managed
Mhm.
and still have a problem, and you're like, "What in the world?" But then
Boom.
we have an answer,
Right.
right? And I think that what a be like, "Oh, you have an answer for this one too? This is awesome," right? Like, that would be like, because 'cause you'd be like you'd feel so good, and then again, just the roller coaster of emotions with that,
Right.
and to be able to kind of find a way to end up on top
Mhm. And
would
I
be
think about the
awesome.
frustration of patients in that instance because say they do manage that condition. Well, then you can't really go into your provider's office and say, "I'm still having a problem." I mean, you can, but really it's like, "But we did fix it, right? We did manage
Mhm.
it." And then as a patient, you're like, "Yeah, I guess you're right. You know, I'm no longer having reflux." But again, like, meet them where they're at, that's not enough.
Yeah.
They're still having a symptom that's interrupting their quality of life.
I think that's the cool part about the functional GI program too, is you get to see that all the way through,
Yeah.
right? Like, even though you think you might have, fixed or, managed whatever that first part is, they come back and they can come back. They have that ability to, and you
Mhm.
can continue to see them through to the end, right?
Right.
Whatever end means for that individual. So,
And like I mentioned earlier, that cycle too. So somebody might be very well managed, be very happy where they're at, and they don't see us for a while. But something happens in their life and things aren't as good as they used to be. You can come back, right? We can look at the picture how it's different the second time around. Say you had like a terrible stressful life event and you you were someone that really is affected physically by your mental and emotional stress and you really managed it. You changed your diet, you changed maybe your coping mechanisms, maybe you even had some psych involvement and you got on a medication that really helped. But again, like what if the world comes crashing down and now all of a sudden you're not doing so well? Like it's come back, you do it again.
go back through it. And that might look a little bit different, I'm assuming
And it
too.
might look different time too, right?
That's so cool. Well, I don't have any. Is there anything you want to really specifically touch on?
Are there any I should say a question
Y-
for your question. Yeah.
Yeah.
Are there any like specific instances that you would have questions on? Like, can you think of anything in your practice that
Hmm.
you know what I
You
mean,
know,
that you feel like, "Oh, would this have been a
yeah,
Sure,
good person for that?"
sure.
I
Or
got it. Yeah,
Do you have one? No, you
I got a
go.
good one. We actually kind of talked about this, but I think it'd be good for this people to hear is so GLP-1s and
yeah,
sometimes weight loss medications can cause some GI complications, right? Whether that's
absolutely.
slowing it, usually it's slowing it down, gut motility.
Mhm.
Um, would those individuals be good functional GI candidates? Or, yeah, leave it at that.
So, this is kind of one of those chicken or the egg thing, right? Like, I've got slow gastric emptying. So, maybe, like, my GERD got worse or maybe, my bowel movements are now not so regular or maybe I just have that, like, chronic nausea, which I feel like you get a lot with your GLP-1 people. And so, I can say those are very functional they look like very functional problems, but we know why they're happening, and they're happening because of most likely because of that GLP-1 in this instance, in this example, but I still think that there's aspects of the functional program that will help that person. So, going back to how do we manage those symptoms to get you the quality of life? So, I think it's going back to looking at the nutrition of it. Are there dietary strategies that we can use to kind of maximize your digestive efficiency while you're on this medication. Is there anything we do need to manage from a mental health standpoint that's maybe exacerbating these conditions? In that case, we probably are not looking at ST or PT. Maybe
Mhm.
not the program as a whole. I wouldn't define those as functional GI issues, but we can use the techniques.
Absolutely. So to summarize a little bit, like, I would assume so you don't need to necessarily go to the functional GI program or through the program. However, thankfully here at Iowa Weight Loss too, like we also have you can go to our dietitians or also go see a mental health therapist or try both and
Mhm.
see if that will help resolve some of those symptoms.
Yeah, and then, at the end of the day, say that doesn't, then I think that's a great referral to make to one of our GI nurse practitioners.
Awesome.
Try to manage it on the backside of kind of where we know those symptoms are coming from, and then if you still don't get anywhere, then I think that's a great place to kinda loop the GI team in, and maybe they can look at something a little bit differently.
Awesome.
That's
All
all I
right.
got.
I think that's a good kind of a good place to put a
Yeah.
pause on it. If anything that we've talked about is something that you're curious about or want to hear more about, don't be afraid to reach out to us on social media, of course, to get those questions in and um, find Iowa Specialty, Functional GI. Like, get yourself in that program. If it's something you're struggling with, don't wait. Just go get started because, as you've heard today, it is a little bit of a process to work on managing some of these issues. So
Yeah.
the more days you wait, the more days you're not getting closer to that management. So I think that's all we've got. Thanks for joining us today. This was
Yes.
awesome. Such a
Thanks for having me.
cool
Yeah.
talk and cool discussion. So
You're
perfect. Well, this
welcome.
was the Well-ish podcast. Keep looking out for more episodes on all your different platforms. We'll see you later.
I'm not gonna do it.
I was like, "Is there a closing?"